Hey, so thanks very much for inviting me to talk at the meeting, and apologies that I can't be there in person. I really wish I was, but hopefully this will work. Uh, so I'm going to talk about the importance of intelligibility in machine learning when you want to use machine learning safely. And of course, this is the topic of the entire meeting. And I'm going to focus not so much on images, I'm going to focus more on tabular data. Before I start, I just want to thank a lot of people. We've been working on this about 10 years. In red, this is a bunch of great grad students. Green is a bunch of developers at Microsoft. I have a bunch of MDs here in brown, some other faculty from different universities in black, and then some other collaborators, researchers at Microsoft. Okay, so let's just jump in with a brief history of machine learning. Machine learning has changed a lot over the years. Perceptrons, k-nearest neighbor, then decision trees, then neural nets that have a hidden layer so they can do nonlinear things, then Bayes nets and SVMs, then ensembles of trees, boosted trees, and random forests. And then, of course, the big revolution that happened 10, 15 years ago, deep neural nets. Interestingly, though, as good as deep neural nets are, we find that gradient boosted trees and random forests are still actually more accurate on most tabular data sets. So that's kind of interesting. Deep neural nets are sort of king of the hill on images and text. Now, of course, we have something very exciting. We have large language models like ChatGPT, but and they're going to be around for quite some time. An interesting question is whether these large language models are going to be good at tabular data or whether we're going to see other algorithms still be best for tabular data. And what we're finding is that, as many of you would agree, data scientists, want to use machine learning methods that one way or another are going to be interpretable. So either black box plus an explanation method, or they want to use a model that's interpretable right out of the box. And we're going to talk about glass box machine learning methods that are designed to be interpretable from the very beginning. Now, you might think, oh, it doesn't make sense to use glass box methods because you're going to take a hit in accuracy. The black box methods, deep neural nets, boosted trees, random forest, are the accurate methods. And if you're going to use glass box methods, say linear logistic regression, things like that, you're going to have to lose some accuracy. The good news is that if you're working on tabular data sets, and by that I mean data sets where you know what the features mean, the patient's age, the patient's blood pressure, their heart rate, things like that, those would be tabular clinical data sets. This trade-off doesn't exist. We have a learning method that we're going to talk about today, these explainable boosting machines, which are just as accurate on tabular data as any of the black box methods. And yet they're even more interpretable than some of our glass box methods like linear and logistic regression. I'll give you examples of that. So let me just give you some evidence for this. So this is 10 classification data sets. The first column is the test set AUC for EBMs on these data sets. And the bottom is the average AUC, and it's 0.866 across these 10 data sets. And on the right, we have full complexity models. For example, we optimize gradient boosted trees to be the right depth for these problems. And notice that the average AUC on the 10 problems is also 0.866. So it turns out that the glass box methods and the black box methods are performing about the same. Now, sometimes the glass box method's better, sometimes the black box method is better, but on average, they have very similar performance. And we usually see they're very, very close to each other. Now, take this with a grain of salt. I'm one of the authors of this paper, so maybe you don't want to trust the results. But here's some results from Cynthia Rudin and her students at Duke. And they used our method, our open source package for EBMs. And they found that, one, we were the most accurate of all the glass box methods. And they also observed that the best glass box methods, EBMs, perform about as well as the best black box methods, again, gradient boosted trees in their experiments. So that's great. So we have confirming evidence that these glass box methods, despite the fact that they're designed to be interpretable, can be just as accurate as black box methods. And just so you know, I won't talk about this further today, but we've also done some work where we can train neural nets to be this interpretable as well. We basically restrict the architecture of the neural net, so it has to learn glass box functions. And we find in our experiments that the accuracy of EBMs and neural nets, these NAMs, neural additive models, are comparable on several different data sets, both in regression and in classification. And this is a collaborative work with people at Microsoft, people at Google, and with Jeff Hinton at Toronto. So If you're interested in this, please get in touch with us and we can tell you more about it. And there's a paper from 3 years ago on this. Okay, let me tell you what these EBMs are. They're what's known as a generalized additive model. The simplest additive model is linear regression. So this blue line would be a straight line you would get with linear regression. The red is what happens if you pass the regression model through a sigmoid in order to predict probabilities because you want to do classification. Gold standard for interpretability. Sadly, because it's linear, it's not very accurate on modern data sets, and that's because it can't model nonlinearities. It can't do things that are very important in healthcare, such as normal is in the middle, and if you're hypothermic or feverish, that's higher risk, but normal temperature is lowest risk. It can't model things like that. So you end up having to do clever feature engineering in order to represent these things with a linear model. And by the way, sometimes these linear models even get the signs wrong. They struggle so much to fit the data because it's not linear that they'll end up getting the sign wrong on some of the terms. So it's even dangerous just to look at whether you have a positive or negative association. At the other extreme, we've got black box models. You know, this is boosted trees, random forests, neural nets. Not very interpretable. That's why we call them black box, but they can be very accurate because they can model nonlinearities. And in particular, they can model things like normal in the middle, higher risk at either end. They can model cup-shaped and hat-shaped phenomena very easily. However, because these are pretty complex models, they do tend to overfit and learn some spurious high-order effects. So if you use something like SHAP or LIME to open up this black box and try to understand what's inside of it, you'll often find that it has learned some spurious effects in addition to the real effects. So these models can be misleading because they can learn overly complex functions. Now, in the middle is sort of the sweet spot. Generalized additive models, of which EBMs are one example. These, surprisingly, I'm going to give you lots of examples, can be more interpretable than linear and logistic regression. So here's a graph. Notice that we have low risk here. Risk goes up pretty rapidly as the value of the feature increases, and then it flattens off. And risk also increases a little bit as you go to the left of normal. Now, of course, the linear model can't really represent this. It would just have to be some approximate straight line that sort of splits the difference between all of these effects. But in the hands of an expert, this kind of graph is very, very interpretable. They often put meaning to why risk is rising rapidly, why risk flattens off, why there's higher risk if you're at the low side as well. I'll show you graphs that look like this. So these things can be very interpretable to experts. They can be very accurate as the black box methods, and that's because they're designed to model nonlinearities. And they can easily do cup-shaped and hat-shaped phenomena. And importantly, because these models are restricted to be simple enough to be interpretable, they tend not to learn spurious effects. That is, most of what these models show you are real statistics in the data, which is good. Now, we didn't invent them. Generalized additive models were invented in the late 80s by Trevor Hastie and Rob Tibshirani at Stanford, two very famous statisticians. And they invented them for all the reasons we want to use them. But think about it. They invented them before the internet had happened, before big data sets had happened, before big computers had happened, and they invented them before most machine learning had happened. So our contribution is going to be to use modern machine learning tricks and modern computing horsepower to really make these things fire on all cylinders, to really put them on steroids. And in the process of doing that, we're going to get an accuracy out of them that even their inventors did not expect was possible. We really are going to take this model class, which has been around now for 40 plus years. We're going to get this model class performing as well as the black box methods. And we're going to do that without hurting intelligibility. In fact, as a bonus, we're going to improve intelligibility in the process of doing that. So that's great. Let me show you what these are mathematically, and then I'll just jump into a bunch of examples. So on the left here, we've got a linear model, intercept, slope times feature, slope times feature. On the bottom, well, we've got full complexity models. I won't write what the function is for that. It's just some function of all the features, okay? This is a generalized additive model. It is a function of feature 1 plus another function of feature 2. So every feature has its own function, and that function can be nonlinear, multimodal, complex. And then they're combined with addition, which means that you can kind of look at this function separate from this function, separate from this function, and that aids interpretability. So this is the simplest generalized additive model, but in some ways it's a little too simple. We're going to make it more complex. So this is the sum of functions of individual features. That's the line up above. This is the sum of functions of pairs of features. So now we can do pairwise interactions. This is the sum of functions of three-way combinations of features. So now we can do three-way interactions. And usually what we'll do is we'll restrict ourselves to main effects, functions of individual features, and then a small number of the most important pairwise interactions. And we'll restrict ourselves to this model class because it remains interpretable. So once you get to three-way interactions, it gets harder to understand these things. And also, to our surprise, if we do this really, really well, we're able to get an accuracy out of this model class that's comparable to black box methods. Okay, I'm going to jump in. You may have seen this pneumonia example before. Apologies for that, but I'll give you a lot of other examples that are not this pneumonia data set. But we're going to spend a few minutes on this so you get comfortable with the model and you understand how it works. Okay, this is an old data set from 1989, really old data. Got 46 features. This kind of model is a function of a feature plus a function of a feature. So we're going to have 46 functions, one for each feature. And then we're going to throw in 10 pairwise interactions. So we'll actually have 56 functions and we'll have an intercept term. Okay, let me show you what that looks like. From a really high level, we've got a function of risk. We're trying to predict the chance that the patient would die from their pneumonia. So we're predicting mortality here. So we have a function of risk on the vertical axis as a function of age, as a function of asthma, at the bottom as a function of blood urea nitrogen. Now we've got 56 of these graphs. I'm not going to show you all of them. And the way you use it is you find the patient's age on the x-axis, and then you read off some contribution to risk on the y-axis, and you write that number down. It's an additive model. So you're going to get a term from each function, from each graph, and then you add all those numbers together. And in this case, we're doing classification. So these are logits. These are on a log scale. They're like log odds. And these are exactly what would be coming out of your neural net at the last layer of hidden units, if you were then going to go into a sigmoid, which was going to compute a probability of mortality. So those things coming out of those hidden units would be logits. And that's what these are, okay? Now, if you were doing logistic regression, this is the formula for logistic regression, 1 over 1 plus e to the minus score, where the score is the sum that comes from all of the terms in the model. Now, if this had been a linear model, then all of these graphs, you wouldn't bother to plot their graphs because they'd just be straight lines. It's easier to just look at the slopes, the beta coefficients, and it would be a linear model up here in the exponent. But this is a nonlinear model, so we don't have these straight lines. And instead, it's as if we're doing logistic regression with all of these nonlinear components up in the exponent here. So they're what gives us the score. And this is exactly how logistic regression works. You can think of generalized additive models as being a generalization of logistic regression in this case. And just so you know, these scores, they really are on a log scale. If you predict a score of 0, then this formula will predict a 50-50 probability of mortality. If you predict a +1, it'll be a 75%, +2, 88%, +3 will be 95%. So you're familiar with these numbers from hypothesis testing. So, and what this means is, remember, we're going to get a number from each graph. If a graph gives us a number for some patient that's like +0.5 or -0.3, it turns out those are big numbers on a log scale. So what look like small numbers for each feature can be fairly large by themselves. And then we're going to add 56 of them together. So if we end up adding a lot to a patient's risk by adding up a lot of smaller effects, the patient could be very high risk, or going the other way, very, very low risk. So it's very important to keep in mind that these are logs. Okay. Let me show you what the model has learned about the chance of dying from pneumonia as a function of the age variable. Now, remember, there's 56 plots in this model, 46 features, 46 main effects like this, plus 10 pairwise interactions. I'll only show you a few of them. All of these graphs are learned together. This is not marginalization. We're not looking at one feature at a time. These are all learned together, and they're designed to work together. At the bottom, we just have a histogram. Most patients are between 60 and 90. We have some patients who are younger, 20s, 30s, and 40s, and a few patients who are over 90. This is the risk plot at the top. Remember, down is lower risk, high is higher risk, okay? And let's read this model. Remember, this is a log scale. So Well, lowest risk is like everybody under 50. So it's good to be young. Risk goes up a little bit as you go through your 50s into your 60s, but not too bad. Interesting rise in risk at 67, 68, 69. This is data from the US. This is a retirement effect. There's a lot of changes to people's healthcare that happen at retirement in the United States, not necessarily in other countries. We often see this sort of effect in US data. We would see a different region of the graph here if this was a pneumonia data set from the EU. And then risk continues to rise pretty rapidly as you become elderly. That's to be expected. A surprising step function rise in risk right at a round number at 85, surprising flatness in risk in the upper 80s and 90s, and then a surprising drop in risk, step function drop in risk right at 100, 101. This rise in risk at 85, there is nothing in US healthcare policy that says you should treat patients over 85 differently than patients under 85. And we don't think there's any phase change that's happening in biology where it suddenly recognizes you've gone around the sun, 86 times as opposed to 84 times. What we think is happening here is we think that clinicians are giving less aggressive care to patients who they view as being extremely elderly. So the idea is, well, grandpa is 86 years old. He has the illnesses associated with being this old. Because of those illnesses, grandpa now has pneumonia. The first 2 rounds of antibiotics have not helped. They have not made the pneumonia go away. Maybe we're not doing grandpa any favors by continuing to fight. Life expectancy in this older data set is about 80. So people who are 86 and above are really quite elderly in this data set. And we think that clinicians, could be the patient themselves, it could be the spouse, the children of the patient, are collectively making an unconscious decision to just be a little less aggressive in the care for some patients who are over this round number of 85. We think a similar social effect is happening at 100, 101. So I'm at, you'd have made it to 100. You're a centenarian. Maybe the patient's 101st birthday is 2 months away and they've got pneumonia. No clinician wants a patient who's made it to 100 to die from something like pneumonia on their watch. They want to go for the record. And maybe the patient wants you to go for the record as well. And maybe the grandkids of the patient want to go for the record. So pneumonia is a reasonably treatable illness. If you fight hard enough, you can often get the patient past it. So in what we see is evidence that right around 100, 101, we see evidence that the clinicians are fighting extra hard to rescue these patients and to get them past the pneumonia. And by the way, I've talked to doctors and they tell me that this is definitely true, that basically once patients have made it to 100, if they have a treatable illness where they have a chance of being able to get the patient past it, they'll do everything they can to rescue this patient. They'll fight extra hard, basically. And they won't do this if it's a terminal illness. You're not doing the patient any favors by just trying to have the patient survive another month or two if their illness is terminal. But if it's something where you think there's even a chance of rescuing the patient, clinicians will often fight extremely hard if the patient has made it to being 100. Okay. I want to back up for a second. Remember, there's 56 graphs like this. We can't look at all of them. They all tell interesting stories. I've just told you a really detailed story about risk of dying from pneumonia as a function of just one of the variables, age. It's good to be young. It doesn't distinguish between people who are 20s, 30s, and 40s, even though it could if it needed to. Then risk goes up slowly. Then there's a retirement effect in US data. Getting elderly, of course, puts you at higher risk. There's like a interesting jump in risk at 85 just because you're considered quite elderly, at least in this very old data set. This jump tends to disappear in modern data because 85 is not that old anymore. And then there's this interesting drop in risk at 100, 101. This model is the most accurate model anyone has ever been able to train on this data set. Now, it turns out a neural net is almost the same accuracy. They're not statistically different. But I just want to point out this is a really accurate model, and yet we're completely able to understand it. And this is how the model works. Although we train millions of boosted trees to generate these graphs, once we generate the graphs, we throw the trees away. This really is how the model makes its prediction through these graphs. So this is kind of wonderful that we have a very high accuracy model where we can see this amount of detail. Now, be careful. The model isn't telling us, that this is a retirement effect and why there's a jump at 85 and why there's a drop at 100. That's us doing detective work to trying to understand what the model has learned. The model is just telling us exactly how it makes predictions. Okay. So we're the ones who are looking at the model and trying to put an interpretation on why it might have learned what it learned. Now, there's something else. This model is not only very accurate and interpretable, but because the model is these graphs, we can edit the graphs. We can change them if we have to. And clinicians know that a 105-year-old is not actually lower risk than a 95-year-old, except maybe because they get better care. So we can edit the model to make risk go monotonically up, say, starting at age 85. And if we edit the model, it will do this. And this is great because now clinicians trust using this model more in the real world, where they know that 105-year-olds are not actually lower risk than 95-year-olds. So we can make this edit to the model. Interestingly, accuracy on the test data goes down slightly. And that's because our test data is a retrospective sample of our training set. So the statistics that are true in the training set tend to be true in the test set. So it turns out our test set also suggests that people who are 105 are lower risk than people who are 95. And the model is rewarded for predicting this. And when we change the model to do this, it's actually going to make slightly less accurate predictions according to the test set. But it turns out the test set has treatment effects in it, and we don't want the model to be modeling those treatment effects. So that clinicians are confident that even though accuracy on the test set goes down when we make this edit, that in fact accuracy in the real world, the safety of the model will go up. So that's very, very important. We'll talk more about that. Do you always want to make this edit? Well, no. If you're an insurance company in the United States, then maybe you're not going to intervene in people's care. And you just want to know what the survivability of patients of different comorbidities and ages are. So you don't need to edit this model. You might be interested to understand the model in the first place. It's kind of an interesting fact that people over 100 are a little more likely to survive than people in their 90s. That's a really important fact. Whether a model is right or wrong, accurate or not, depends in detail on how you will use the predictions of the model. There's no such thing as saying the model is accurate without also specifying exactly how the predictions will be used. There are different edits, changes we might want to make to the model or the data, depending on exactly how we're going to use the prediction. Let me show you some things this model has learned. There are jumps all over at round numbers. I'll show you more of those. Those are almost always in medicine due to human social policy changes, treatment thresholds and things like that. There are very few phase changes in biological systems. The model has learned, interestingly, that having asthma, which is the right side of this graph, lowers your risk. That is, if you've got pneumonia, asthma is good for you. The model has also learned that having a history of chest pain and having a history of heart disease, which I'm not showing here, that's good for you if you've got pneumonia. And the model has learned that a kind of wheezing called stridor, which is a sign of advanced pneumonia because you've got blocked airways, that's good for you. So the model is saying, like, if you've got pneumonia, it's better to have advanced pneumonia. None of this makes sense, right? Clinically, none of this makes any sense. So why is the model learning it? Turns out all of these things are real statistics in the data. Well, what the doctors tell us is that, the asthmatics are paying attention to their breathing. They're having some symptoms. They try their med. Maybe it's an inhaler. It doesn't work. It's not designed to treat pneumonia. They have a doctor who treats their asthma, so they know who to call. They call the doctor, and the doctor says, oh, the inhaler didn't work. Get in here right away. They get an early appointment. The doctor diagnoses, hopefully, that they've got pneumonia. And the doctor is thinking, wow, you've got a history of bad asthma. Now you've got pneumonia. They treat the patient very aggressively. Two things have happened. The patient has gotten to care quicker, and the patient has gotten more aggressive treatment once they get to care. And those things are so valuable if you've got a treatable illness like pneumonia, that they actually lower the risk of patients who are otherwise less healthy because those patients got to care faster and they got really high quality care. Same thing's happening with heart disease. If you had a heart attack maybe 3 years ago, or you've got, recurring chest pain from heart disease, and you wake up in the morning and your chest feels funny, you don't know it's pneumonia. You're not a clinician. You're afraid it might be a heart attack. If you're smart, you're in an ambulance. You get to the emergency room really fast. You get to the front of the line. They put probes on you. Within a minute, they know you're not having a heart attack. They diagnose that you've got pneumonia, and then you're already in the emergency room. So you get incredibly high quality care because they know you have a history of heart disease and now you've got pneumonia. So again, rapid treatment really helps these patients lowering their risk. Well, how can advanced pneumonia, stridor, be good for you? That doesn't make any sense. Well, imagine two patients who are equally high risk, and one of them has silent symptoms. The other patient has stridor. That's a kind of wheezing you can't ignore. You're going to pay attention to the stridor. You're going to go to the emergency room and you're going to get treatment. And it turns out two equally risk patients, the patient who has the symptoms that they can't ignore and forces them to get treatment earlier will be lower risk because they will get care, whereas the patient with more silent symptoms may not get care as rapidly. And that puts them at higher risk. So if you're going to get a treatable illness, it's important, or at least valuable, to get symptoms as early as possible that are bad enough that they'll force you to go to get to care, because earlier you get care, usually the better. Okay. Now, clinicians know that none of this is true, right? It's all true statistically in the data, but none of it is true about pneumonia in general. This is what happens after you take treatment effects into account. So clinicians would like us to edit these models so that we flatten the risk for asthma, heart disease, and stridor. Or they want the asthmatics to be higher risk, the heart disease patients even higher risk, and the advanced pneumonia patients to be the highest risk. And we can do that. And again, if we do that, the accuracy of the model on test data will go down because the test data actually looks like this. So that's very interesting. But it's even worse, right? The model is additive. So think about it. If you leave the model like this, it's going to predict that a 105-year-old with a history of asthma who had a heart attack 3 years ago, has recurring chest pain, and who now has advanced pneumonia is ultra low risk, because all of these things, if you don't edit the model, predict the patient's lower risk. And yet a 105-year-old asthmatic with heart disease and stridor is one of the highest risk patients you could possibly have in the data set. So you have to be able to recognize these things and edit them. Even worse, the model was rewarded with extra high accuracy on the test set for predicting these crazy things. So it's really, really important that we can see these things and correct them. And it means that you can't trust accuracy on retrospective test data. You can only trust accuracy measured prospectively once a model is deployed. So intelligibility is valuable so that you can understand the model, possibly correct it before deployment. Now, you might think you could solve these problems by removing a feature like heart disease or asthma, from the input of the model. That doesn't work. Turns out there's enough correlation between, say, heart disease and other features like diabetes and hypertension and age, that even if you remove the heart disease feature, the model will still try to predict that heart disease patients are lower risk because of correlation. And what you have to think of is that the bias is actually coming into the model through the training signal, through the target. It's not through the input features. So you don't solve these problems by removing features. I think we all know at this point you can't make a model unbiased by removing race or gender from the input features. There's enough correlation between race and gender and other things that the model is still going to be biased because the training data is biased. The targets are biased. It's the same thing here. So you have to solve these things by detecting them in the model and then handling them a different way. Hey, I've been telling you some terrible things, right? We have to edit the age graph. We have to edit the asthma, heart disease, stridor graphs. Wow, you might think we have to edit everything. It's all bad news. It's not. Actually, most of what these models learn is really good. And sometimes you can learn from the model. You can actually get new science. This is pneumonia risk from your blood urea nitrogen level. That's a blood test we've all had. And this is exactly what clinicians expect, which is that risk starts to go up at around 30, 35, and it continues to go up. And then notice it flattens at 50. 50 is a round number and it flattens right at 50. That's interesting. Then it starts to go up and it peaks at 100, another very round number. And then it actually starts to come down. And clinicians say, well, this isn't really right. Risk just keeps going up as your blood urea nitrogen gets higher. So what we're seeing here is treatment effects. So they start to give a medication at 50. And at 100, they start to give dialysis. And both of these are so effective that they either flatten the risk curve or they actually make the risk curve go down. So that's great. So we're seeing the effect, the beneficial effect of treatments in the model. That's wonderful. So clinicians really like this graph once they understand why it's learning it. But clinicians are kind of disappointed that, patients who are less healthy with a BUN of 120 actually have lower mortality than healthier patients who have a BUN of, say, 90. So, and they find that sort of disappointing. Now, it's real. Statistically, this is real. It just means that their clinical practice is not as good as it could be. They're using round numbers like 50 and 100. And we're able to estimate that if we were to move the dialysis threshold from 100, say, down to 85, that risk would look no worse than this red line. It would probably actually come down below it, but this is a conservative estimate. And then the area between the red line and the original curve, that's lives saved. In the United States alone, we would save 2,500 to 5,000 lives per year by making this one change in one treatment threshold for one condition, pneumonia, for one blood test, blood urea nitrogen, and for one treatment, dialysis. And the US is only 3% of the world's population. So this is more than 50,000 lives per year that could be saved by making this one change to the way healthcare is provided. So it's amazing what you can learn from an interpretable model. Okay, treatment effects are all over. This is systolic blood pressure, the higher of your two blood pressure numbers. And notice that risk goes up near 175, then comes down at 185, goes up around 200, comes down around 220. It's not the case that 220 is a better blood pressure than 200. What we're seeing is that at different round number thresholds, different treatments, more aggressive treatments are being given to the patient, and that's why the risk starts to come down. And then you hit another threshold, and an even more aggressive treatment is used, and risk comes down again. So what we're seeing is the effect of treatment. Without treatment, this graph would just be consistently monotonically increasing with increasing blood pressure. Let me show you what a pairwise interaction looks like. So this is risk as a function of age on the left. We saw that graph before. And this is risk as a function of cancer on the right. So the cancer patients are significantly higher risk of dying from pneumonia than the non-cancer patients. But just like exclusive or parity functions, there are some things you can't learn by looking at the features one at a time. You really have to treat them together. So this is an interaction. We have cancer on the x-axis. We have age on the y-axis, and then we have a contribution to risk in color on the third axis, on the z-axis. And notice this group at the bottom here. These are very young patients who have cancer, and we're adding a lot to their risk. 0.5 is a lot. On a log scale, that's a big increase in risk. So why would the youngest patients who have cancer be at extra high risk? Turns out we give a more aggressive treatment to young cancer patients than to old cancer patients. And that's because the young patient can often withstand the treatment that an older patient wouldn't. In the process of giving them such an aggressive treatment, we sometimes knock out their immune system. If we knock out their immune system and they have pneumonia, which they have to be in this data set, then they are at extra high risk. And the model has figured this out all by itself. It basically has recognized that there's a special group of young cancer patients who, for whatever reason, are extra high risk. And then by talking with clinicians, we're able to figure out that it's because the treatment that the young patients have received has knocked out their immune system. Okay, now I'm going to go really quickly through a bunch of examples, and then we're going to wrap up. This is ICU mortality, chance of dying in the ICU. This is PF ratio. It's a measure of how well you're breathing. If you're down near 0, you have very little oxygen in your blood. If you're near 1,000, you're doing great. What's interesting is this spike that's happening right here. And what's interesting about this spike is it has the same low risk as the healthiest patients, and yet it's in a region of poor PF ratio. So it turns out this data set had 60% missing values for PF ratio. They pinch your finger. If pink returns quickly, they don't bother to measure this test because you have good blood oxygen. So 60% are missing the PF ratio. It was imputed with the mean. The mean of the feature turns out to be 323.6. So we have a large number of very healthy patients sitting right here. And the model's doing everything it can to predict the patients just to the left and right of this value are higher risk, but right at this value, they're low risk. That's unfortunate. And you can't solve this problem just by editing. If you edit the graph to get rid of the spike, then it turns out if you're still imputing missing values, you'll predict that a lot of people are higher risk. But if you leave it the way it is, it's actually fairly accurate. But anyone who has a real PF ratio of 323 who falls in this region of the graph will be predicted as being low risk, and that's dangerous. So it turns out you have to handle the missing values some other way than imputing with the mean. And I won't talk about it now, but intelligibility has completely changed how we think about missing values. What we do is maybe we have 5 different ways of handling the missing values for each feature. We'll try all 5 of them. We'll train an interpretable model on each of those copies of the data set, and then we'll compare the graphs side by side, and we'll figure out which way of handling missing values seems to be working best. And remember, you can't trust accuracy. It's not that the highest accuracy method is best, because often that's misleading. So you really need to look at the graph, understand what's happening, and then figure out how to handle the missing values. Severe maternal morbidity. This means that during delivery, something bad has happened to the mother. Mother had a hemorrhage, needed a blood transfusion, possibly needed a hysterectomy, eclampsia, things like that. And if you ask clinicians, what are the main risk factors for a mother to have maternal morbidity during delivery, they'll say, well, if the mother has a history of hypertension, diabetes, obesity. We throw this interpretable model at some data. It completely agrees, by the way, that these are very important factors. But it says two factors are more important. The single most important factor is the size of the baby. The larger the baby, the higher the risk to the mother and to the baby, it turns out. And that makes sense. A larger baby is going to be a more difficult delivery. The second most important factor is the height of the mother. And this is our best estimate of the size of the pelvic opening. Taller women tend to have larger pelvic openings. The larger the pelvic opening, the lower the risk, because the easier the delivery is going to be. So right away, a large baby coming through a smaller pelvic opening is going to be a very difficult delivery, probably. And a smaller baby coming through a larger pelvic opening will be a much easier delivery. So we created a ratio of these things. This is the baby's weight divided by the mother's height squared. So this is the definition of body mass index, but now it's for pregnancy. And when we do this, this ratio immediately becomes the single most important feature for predicting severe maternal morbidity. Now, we could let interactions handle this, but it was more fun to just create the feature ourselves. Let me tell you quickly about a cancer clinical trial, collaborators at University of Pennsylvania. This is risk as a function of age. Notice that risk of dying goes up with age, as you'd expect, and then it drops at 76. So, and that doesn't make any sense. So we asked the clinicians who were involved in this cancer trial, what's going on? And they laughed. They said, oh, you know, to be in our cancer clinical trial, you had to be 75 or younger. And if you're over 75, the only way you were allowed into the trial is if you were extraordinarily healthy, and this was considered the most appropriate treatment for your illness. And the doctor basically said, you know, our 80-year-olds actually are healthier on average than our 65 and 70-year-olds. And your model has detected that there's a selection bias in our cancer clinical trial. This is part of our guidelines for admitting patients to the trial, and your model has detected it. Now, if you're going to use this model more broadly, if you're going to use the model just for the cancer trial patients, it's fine to use this risk curve. But if you're going to use the model more broadly, you have to either flatten this risk or even make the risk go monotonically up. You can't leave it the way it is. Let me tell you about COVID-19 mortality. So this is risk as a function of age. Hey, this is a respiratory illness, kind of like pneumonia. A lot of similarities here. We see jumps at round numbers, like we see a jump at 85, like we saw in the pneumonia data set. And being young is lower risk. You know, a lot of things that we saw before. This is what's really interesting is there's a large rise. This is +1 on a log scale. That's 3-to-1 odds ratio at age 95. That's really interesting. So what's going on there? Remember, we saw a drop in risk at 100 in the pneumonia graph. Risk actually went down above 100. Here we're seeing a big rise above 95, and it stays true no matter how old you are. Well, it turns out in the first 6 months of the COVID-19 pandemic in the US, they had do not intubate orders for patients who are over 95. Intubation is a very aggressive procedure. You don't give it casually to old patients. So they had do not intubate orders. It's not because they didn't have enough equipment. They actually thought medically it was not the best thing to do for very elderly patients. And if you look at this graph, you can see that there's severe consequences in mortality for having that do not intubate rule. So this is a really valuable thing that you can learn from these graphs. And doctors, by the way, were very excited to see interpretable models trained on their data, especially early in COVID-19, because they didn't understand how COVID-19 worked and how they should treat it. And they found these interpretable models really helped them make decisions about how to better care for patients. This is the difference between men and women COVID-19. And remember, this is learned in concert with all the other features, just like everything else. Women are significantly lower risk than men. And you all heard that in the early days of the pandemic. say a woman who's 85 and has certain comorbidities, if her risk of mortality was 10%, then the man who's the same age with the same comorbidities would have about a 14% risk of mortality. That's a huge increase in risk just due to gender. This is risk as a function of your lymphocyte count. And this is to be expected, that if you have a very high lymphocyte count, you're at extra high risk. This was a surprise, though. And we had this surprise in the first week of looking at COVID data. The surprise is that patients with very low lymphocyte counts, who you might think don't have an infection, are also at elevated risk. And these are patients who are immune compromised. They're failing to launch an immune response to COVID-19, and that's what's putting them at high risk. And clinicians at first did not recognize this group as being at extraordinarily high risk. So this sort of model can really help. This is fun. These are meds that patients take before they've been admitted to the hospital for COVID-19. And I've turned the graph on the side so that you can read the labels for the meds. And to the left is low risk and to the right is high risk. And we've sorted things. So notice at the top, peptic ulcer disease meds and platelet aggregation inhibitors, these are things like aspirin, NSAIDs, are low risk. And it turns out peptic ulcer disease often contains an NSAID in it. So these are both, we believe, NSAIDs. And they lower risk. So that's kind of interesting. Hold that thought. These are meds that are taken by patients in the hospital once they've been admitted for COVID. Notice that the 4 meds that are lowest risk are factor XA inhibitors. These are platelet clotting inhibitors, antacids, which contain aspirin often, ketorolac, which is an anticoagulation for platelets, and ibuprofen, which is an NSAID. So again, the 4 lowest meds that indicate the lowest risk are NSAIDs. What's really interesting is that in the middle here are full dose anticoagulants. And that would be things like warfarin and heparin, which are the preferred meds given in the hospital for anticoagulation. And it turns out that those meds, for what reason or another, do not indicate as low risk as NSAIDs. So there is a chance that these NSAID meds are actually more effective. And we've asked clinicians about this, and they think this aspirin effect is real, that the thrombosis that you get in COVID is not driven by the things that warfarin and heparin attack. It's instead platelet mediated. It's happening in the in the very extremes of your blood supply, where the platelets have a big effect. And we think that the NSAIDs, because they affect the platelet clotting, actually might have a beneficial effect there. So this is great. This is actually suggesting that a medication that doctors would normally use is maybe not the medication that they should use for clotting in COVID. This is interesting. This is your neutrophil lymphocyte ratio. This is, again, looking at blood cells. And the red is patients who are treated with steroids, and the blue is patients who are not treated with steroids. And notice that there's a fairly narrow range of effectiveness of steroids, and most patients actually are out of this range to the left of it. This kind of helps us identify that there are different cohorts of patients who have COVID-19, and one group of these patients will respond to steroids, but many patients will not respond to steroids, and that's because inflammation is not their problem, blood clotting is their problem, and they should probably be receiving a different therapy. And in fact, the odds are they should be receiving both therapies. And in fact, we've seen evidence over time. This is the day of the pandemic. So this is almost 2 years long on the bottom here. We've seen that the risk due to inflammation, where we're using things like steroids, has actually gone down over time. But the risk due to blood clotting, thrombosis, has gone up. And we think what we're doing is we're better treating patients with steroid-like mechanisms, but we're using less appropriate NSAIDs to block blood clotting. So you can really learn some interesting stuff from an interpretable model. Okay, I'm going to show you one other thing, and then that's it. We're done. So this is 30-day hospital readmission, predicting if you might have to come back to the hospital after you've been released within a month. And there are 3 different ways to use these models. One is global model understanding. That's what we've been doing. Train the model, look at the model, find problems in the model, learn what you can from the model, and edit it if necessary. But we can also use the model to explain the predictions that the model makes for a single patient, and that's really valuable. Let me show you that. Hopefully everybody can see this graph. So this is a patient who's predicted to have a 92% chance of being readmitted to the hospital in the next 30 days. And what we've done is there are 4,000 features in this model. That's a lot of features. We can't look at all of those graphs. And we've sorted them by which contribute most to the risk of this patient. Remember, for each patient, it's just a single number coming off of each of these graphs. So we just sort by those numbers. The single most important feature is 139 fat emulsions through an IV. The patient is being given calories through an IV. Their score is 100, so they fall here in the graph, and that adds 0.45 to their risk. The next most important feature is what's called cyclical vomiting syndrome, feature 3098. This is mentioned in the doctor's notes. So it turns out that this feature is a bags of words feature. So it's a text feature. And their score is 16, so they're here, and that adds 0.38 to their risk. The next feature is amitriptyline preparations, and that's adding 0.35 to the risk. Amitriptyline, it turns out, is used for many things, but one of the things it's used for, it's an anti-nausea medication. So think about it. We've got a patient who has cyclical vomiting syndrome. They're giving an anti-nausea med, and they're vomiting so much that they're being given calories through an IV so that they don't starve to death effectively. The patient, the fourth most important feature is that the patient has been an inpatient 64 times. So they define the right-hand edge of this graph. They've been in the hospital 64 times. That's amazing. And these are often young patients, so it's even more amazing. That adds through 0.32. They've been in the hospital 18 times in the last year. So obviously their average time between being admitted to the hospital is less than 30 days. So that puts them out here. That adds another 0.3 to their risk. They've been an inpatient 10 times in the last 6 months. So they're definitely recently very ill, coming back to the hospital a lot. And vomiting has been mentioned in the doctor's notes 107 times, and that adds another 0.22 to the risk. Okay, we only looked at 6 or 7 features for this patient out of 4,000, and we have a good understanding of why they're high risk. Let me show you a different patient. This has just a normal probability of readmission, just about 8 or 9%. Hey, they've been an inpatient 6 times. That's a lot. A little electrolyte imbalance. It adds 0.06. That's not very much. A DX code for personal, history, hazards of health. This is things like riding your motorcycle at 150 miles per hour. This is not suicide. This is more like, doing things that are just risky for your own health. Oh, they've been into the ER 6 times, so all of their admission has probably come from the ER. Oh, and combat fatigue was mentioned 4 times in the doctor's notes. And they have, maybe acute drug intoxication. That also has been mentioned. So now we have a vet who maybe has PTSD, and maybe they're not taking as good care of themselves as they should be, but this patient has, let's say, normal risk of being readmitted compared to other patients. And the important thing is, again, we only looked at 6 or 7 graphs here out of 4,000 to make that determination. So that's great. Okay, so now let's start to wrap up. We can use this kind of model to do differential privacy, which has been discussed in earlier presentations. And the accuracy of our model, as we increase the privacy going to the right in each of these graphs, the accuracy of our differential privacy algorithm based on EBM stays very high, whereas all the competing methods, the accuracy drops rapidly as you get to privacy that you would like. That's great. And the reason why is just because our model is designed to be simple from the beginning. So it tends to preserve privacy even before we do special things to it to make it even more private. Now, we've talked about editing glass box models. You saw me create monotonicity in the age graph for pneumonia. You saw us do these edits to asthma, chest pain, and stridor. We've built a Photoshop-like tool. This is a complete standalone tool that makes it easy for end users to edit these things. And one of the reasons why this is valuable is we often see noise in graphs, especially after differential privacy, which works by injecting noise. We often see noise like this. This is risk as a function of age after you've done extreme differential privacy. And you can see 78 is high risk, but 80 is low risk, and then 82 is high risk. This is just noise. Nobody believes that 80 is really lower risk than 78 or 82. And the good thing is, you can use this editor to just flatten that, make the curve better. And this is great because differential privacy often creates unfairness. It actually has a bigger impact on cohorts that have less sample size. So this is great to be able to do this kind of edit to say reduce noise. But we can do this automatically. So if you've got a noisy risk graph like this, we can use something called the PAVAC algorithm, pool adjacent violators algorithm, to find the optimal edit so that this graph becomes monotone. And you can do this to the entire graph. You can just do it to a part of the graph. You can make it monotone up or down. And you can see that the edits are fairly significant, and these are optimal in a squared error sense. So that's great. So there's this tool, which was designed with clinicians at NYU. And the tool is designed to be used by people like doctors in order to take a model that we've trained and then to do the kind of editing that we've been showing you. All right, let me wrap up. Hey, every data set you've ever used, including vision data sets, has all of these problems in it. It has bias, confounding, treatment effects, selection bias, missing feature value problems. Every data set has these problems. Every time we apply glass box learning to a new data set, we find some of these problems. And accuracy is not true north. Highest accuracy does not mean your model is doing well if it's on retrospective test data, which is how we almost always start. Models are rewarded with high accuracy for doing terribly wrong things. Without intelligibility and explanation, you absolutely are putting some patients at risk. That's very important. And because the models tend to learn treatment effects, it's actually most likely to learn the wrong thing for the patients that we have the most effective treatments for, which is terrible that you're going to actually predict the wrong thing for patients we already know how to care for. So these glass box methods like EBMs and the neural net version, the NAMs, give you the tools that you need to understand your model, vet it, and possibly edit it before deploying it. It also gives you the chance to learn from your model. And that can improve not only your data science, but it can improve the healthcare as well. So clinicians often discover important medical truths by looking at these models. By the way, everything we've been taught about missing values is only half true. So it's really valuable to have interpretability if you're dealing with missing values, which we often have to do. And these models also, I didn't talk about it, but they help us mitigate problems with bias and fairness that we might see as well, if there are things like social determinants of health. And these EBMs are currently the most accurate glass box learning method available, but there are many other people who are starting to develop comparable methods too. And we have an easy to use open source package called Interpret ML. So we encourage, if you use scikit-learn, if you program in Python, this will feel right at home. It's modeled after scikit-learn. Okay, I just want to say thank you. Hopefully I haven't run too long so that we can't take a question or two. But thank you very much for listening. And thanks again to the organizers for inviting me to present.